All right, so, all right, guys, this is going to be Chapter 1, EMS Systems. We're going to give you guys a nice little intro as to what to expect. Can everybody hear me okay over there? Okay. So
Yeah.
we are going to go through kind of how EMS got started, how it's evolved, your participation, how you're going to be participating in EMS as we know it today. This is just kind of a wrap up of what all we're going to be talking about. I usually kind of skip through these first couple slides because we get to the information anyway. All right, so introduction. Guys, the biggest thing to take away from this slide is that EMS is a system. I cannot stress that enough. I know I talked about a little bit in the intro, healthcare is a system, but EMS is absolutely crucial that you guys can function as a team player because it's not just you out there, right? It's not just you and your partner. A patient calls your cell phone directly and says, hey, I need help. Here's my address, come find me. There's a whole network of people who are doing different jobs to make sure that we can arrive on scene and take care of these patients and get them to the hospital appropriately, okay? So again, there's a lot of different components in EMS. We've got our dispatch system. We've got the healthcare providers who are out there as EMTs and paramedics and AEMTs. We've got fire. We work hand in hand with the fire department. Who else do you think we work with?
The police department.
Yeah, APD is a very big key player in being a first responder in EMS because, guys, the number one thing you're going to hear me stress for this entire course is your scene safety. At the end of the day, if your scene safety is compromised, you're not going on that scene. You're not taking care of that patient. Because at the end of your shift, you need to go home in one piece to your family members and your loved ones, and that is the end-all, be-all stipulation of EMS. If your scene is not safe, it's not your scene, okay? We'll get into that. I harp on that. I get on my soapbox about that. Guys, my husband's a firefighter, so me being a paramedic, him being a firefighter, we have 2 boys at home. I get on him about that all the time. If we question patient's violent or can harm us, or there's any type of chemical exposure, you wait until that scene is clear because you need to come home at the end of the day. Okay, so we'll get on that a little bit later, but just know
Are there clear protocols for that, or is that something that you assess and kind of judge from?
So there are protocols, but yeah, it's going to be a lot of subjective. If you are feeling in any way threatened of your personal safety, then it's going to be a, hey, by the way, this is going on, my scene's not safe, so I'm not going into it at this time. It's a lot of self-judgment too.
Okay.
So EMS is governed by state laws. We'll talk about that in a little bit. All right, so now we're going to talk about the difference between certification and licensure. All right, because there's both of those aspects play into EMS. So remember, I said you guys have to graduate this course. All right, go through all of the hard work, the clinicals, the testing to graduate the course. Then you have to go and test out at registry level, right? You have to pass a cognitive registry exam and a psychomotor registry exam. After you pass both of those exams, you are deemed eligible, you are certified in the eyes of registry, okay? Because it is called national registry. All right, so the National Registry says, all right, you're competent enough to graduate a course and to pass our tests. Now you can go forth in whatever state you live in or whatever state you want to practice in and actually be licensed. Okay, you can be certified but not be licensed to practice medicine. Just because you pass National Registry and you're certified at that National Registry, you can't come to Grady and get a job and go practice your scope of medicine until you have a license from the state level. Yes, ma'am.
So do you have to take another exam to get licensed?
It depends on what state you want to practice in. So the question was, you have to take another exam to get your license. The great state of Georgia just wants your money. All right, so after you pass registry, you'll have registry numbers. attached to your name. You'll pay a $75 application fee to the state. They'll send all your information over and you'll say, hey, I want to be an EMT. Let me pay you money and you can give me my license. All right. Different states have different regulations and they can have, there's federal level, state level, and local level. So like, for example, Florida, if you guys want to go practice in Florida, you have to take a state test. Florida says, hey, if you want us to give you a license, we're going to give you a test. You have to pass it to let us know that you're competent. And then after you pass that test, we'll give you a license. So that's going to depend state to state, but here in Georgia, you just have to pay them money. Okay. All right. So is everybody clear on the difference between the definition of certification and licensure? To practice your scope of medicine, you have to have both. If you pass registry and you get gung-ho and you go out there and you start, practicing medicine on patients, you're eligible for a lawsuit because you don't have a license, right? So just make sure you guys understand you have to have both, and that certification and licensure is different.
So is the certification just like you passed and you're good and you know these things, and the licensure is like the state saying you know things?
Yeah, so your certification is registry saying you're competent. You know all of this stuff, you've passed the tests. The licensure, you can look at it as saying that the state is giving you permission to go forth and apply that knowledge to actually practicing on patients.
Is there a renewal period or process?
Yes, every 2 years you have to recert. And within those 2 years, you have to get X amount of numbers of hours of continuing education, saying that you're being informed and educated on the most up-to-date policies and research and all that stuff, or you can pay the money and take registry again. And then the state will say, okay, if you can pass that test again, then you still know your stuff and we'll re-up your license. I don't know why anybody would want to do that, but.
So if you do the continuing education, you don't need to pay that.
Correct. If you meet the hours of education, the continuing ed, you don't have to retest registry. But it's important for you guys to remember you have 2 different levels that you have to keep current, right? You've got hours that you need to keep your registry current for, and then also your state, because you can let your registry lapse and just keep your state license. We recommend that you guys keep both active at all times, but you have certain hour requirements for each certification / licensure that you hold.
Is it fair to think of it like you're certified by Grady and then licensed by the state?
No,
Not exactly.
not exactly. You're only certified in the eyes of registry. Technically, we let you graduate, so we think you're competent, but you're not certified in any capacity unless you pass registry.
Let your CPR cert go out. Would you do it all
Yep.
over again?
Because that's part of your. Now it does. You don't have to do your EMT all over again, but you have to do the CPR course over again because that's part of your scope of practice. All right, guys. EMS is divided into 4 different licensure levels. EMR is going to be our first one. What does that stand for? Emergency medical responders. So this is going to be the first responders who are not going to have a lot of the knowledge of that you guys, even at the EMT level, are going to have how the human body works, the pathophysiology, the med term. All right, we will see these EMRs as a first responder. A lot of APD or police officers are police companies, districts, I don't know, are moving towards making police officers EMRs. At the bare minimum, EMRs are certified in CPR and first aid. So that means if there's an emergency and they arrive on scene, they can try to provide that patient care until somebody who's higher scoped or licensed arrives on scene. Okay, so a lot of volunteer firefighter are EMRs, certified EMRs, and also police officers as well. Okay, again, usually CPR and a little bit of first aid training, like putting dressings on wounds, putting tourniquets on, that type of thing goes into the EMR. All right, so EMT, this is going to be y'all. Again, guys, I'm going to do my absolute best to filter myself because I know I'm being recorded for all of these lectures. So if I let some colorful vocabulary slip, I'm sorry, I don't mean to. It's kind of part of the territory of EMS to have a mouth like a sailor. So, but I will lovingly refer to y'all as my basic bitches. All right. The term basic is kind of being phased out. Right now, you guys are just being referred to as EMT, not an EMTB or basic EMT, but you'll forever be my basic bitches in my heart. Okay. So your scope of practice, when it comes to interventions and pharmacology and stuff like that, you are pretty limited. Okay. We're starting at the bottom of the totem pole and we're going to work our way up. But you are going to be trained in CPR certification, right? You guys are going to be certified with that, which means on your first day on the ambulance, you can go out and work a cardiac arrest. That's within your scope. All right. There are certain airway adjuncts that you can place in patients' noses and mouths to help control their airway. You can actually breathe for them using the bag. There's a handful of drugs that you guys can handle. And you guys are going to have, well, normally it would be 5 months of school learning all about the human body, everything that goes into healthcare and these medical emergencies. You're going to have a lot more training and knowledge than a first responder than an EMR would. All right. So we're not the very bottom of the totem pole, but we're starting out at an introductory level to the human body and pharmacology and all that stuff. Okay. AMT, that's going to be your next step up if you continue in this career, is the advanced EMT. This is a fairly recent addition to licensure. This is a fairly new scope of practice. They started this to be kind of in between the basic level, the EMT level, and the paramedic level. All right. So as an A is what we usually refer them to. You get to do a little bit more stuff. All right. You get to start the fun, the IVs. You get to put the needles in people's arms. You get to start IOs, which means you actually drill into people's bones to have access to give fluids and medications. Sometimes that gives people heebie-jeebies, but you get to do that at the A level. There are more medications that you can handle. There are more advanced airway tubes that you can place. And you go deeper into the pathophysiology or the why things are happening at a cellular level. All right. So again, it's a step up from you guys. You're not quite at the top tier of EMS with the A, but we're working our way towards that. Okay. All right, so paramedic is the top tier of EMS. Guys, this is a lot more schooling. You get a lot more free thinking capacity. You get a lot more interventions when it comes to medications. At the state level, I believe I can handle over 300 medications as a paramedic. I can interpret cardiology. So that means if I put those stickers on your chest, and you get a printout of those squiggly lines, I can look at those lines and say, okay, this part of your heart is not getting oxygen. This part of your heart is dying. This is what this arrhythmia is. I can interpret that. You can do more invasive interventions when it comes to airway. We can place airways directly in somebody's trachea or windpipe or air pipe, whatever you want to call it. We can actually kind of cut open and place a tube in patients' airways. So it's a lot more advanced knowledge and intervention, but it comes with a lot more school time and a lot more clinical time. So you guys have, 24 and 26 total hours for clinicals. I had to do over 700 hours for paramedic. So it's just with more power comes more responsibility. Okay, so you'll probably appreciate that, Peter Parker. All right. So again, guys, we kind of talked about this in the syllabus. The whole encompassing being a healthcare provider or a patient care provider is more than just one dynamic, right? We have to make sure we know the content. We have to make sure that we can work well with others, that we can interact with our patients. We have to make sure that we can do these skills, these hands-on skills, and make sure that overall we have these critical thinking abilities to diagnose and treat successfully in the field. So it's not just one, dimension of quality care. It's going to be a bunch of different things that go into making sure you guys are good providing patient care. So just kind of introduction. I want to make sure that you understand the entire capacity of EMS. Because what does EMS stand for? Emergency Medical Services. All right, so you guys are going to be an EMT, an emergency medical technician. Guys, anybody that calls 911 for whatever reason, you're going to respond to that person, right? We'll talk about how we get to that point in just a second. But a lot of people think that every single call you're going to get is going to be lights and sirens, and it's going to be gunshot wounds and people dying and having heart attacks. That is exciting, that is fun, but that's probably maybe going to be like 5% of the calls that you respond to. All right. Especially here with the Grady population, the urban setting, we have some big socioeconomic different branches with our patients. A lot of the majority of your calls are going to be for patients who their prescription ran out and they need to go to the hospital to get it filled, or they stumped their toe on the coffee table and they're going to call you because they think that they need to go to the ER. Or they just have a headache or a stomach ache, or their back's been hurting them for 6 months and they just now decided to call EMS and call an ambulance and they need to go to the emergency room. You're going to see all sorts of different, what we call acuity levels. You're going to have patients that are really, really critical, those patients who are actively dying, right? But then you're also going to have these patients who we deem not critical, a low acuity, a non-emergency response. So you're going to have all sorts of, you're going to be able to work, you're going to have to work on your poker face, because if you show up on scene and you're like, I'm sorry, you called 911 for what? Because you stumped your toe on the coffee table and you've got like a hangnail. We're here to serve the people of the community, right? And it might be that they're just not educated on different routes that they can take. They might not be educated that it's not a life-threatening emergency, that you stumped your toe on the coffee table and you need to call 911. So we can have some educational moments with the community. We have some patients who just know that it's not appropriate to call 911 for these things, but they do it anyway. But just don't forget that you're here to serve the people no matter what the situation is. It's not just going to be all of the pride and glory and lights and siren stuff. A lot of the, okay, I guess we can take him to the ER, calls go into it as well. So don't get that tunnel vision to think that you're only going to be nice or really excited about those patients who have the cool trauma or, are actively dying type thing.
Yeah, I was gonna ask you to define acuity level, but I got it.
Okay. All right, so you guys are going to hear me talk about this the entire duration of the course, right? Your scene size up, your patient assessment, your treatment, packaging and transporting your patient, and then EMS overall. Again, guys, we'll go into what each of these things mean. And then throughout the course, I'll say, okay, here's how your scene size up is going to apply directly to this particular emergency. Or here's how your patient assessment is going to differ for this particular emergency. Okay, so just know, what do you think is involved in the scene size up? Just general.
Assessment of whether or not the scene is safe.
Yeah, so scene safety. That's going to be your number one concern in that scene size up. Is my scene safe?
Locating the patient.
I'm sorry?
Finding the patient.
Yeah, where is my patient? How many patients do I have? Do I have one or do I have 20? Right? Where's my patient located? Anything particular that I need to know about accessing and finding my patient. But yeah, guys, going back to that scene safety, if you get a dispatch to like a domestic call or a shooting, the number one thing that's going through your brain is that the shooter, is the assailant still on scene, right? Because if they are, or if we don't know where they are, or if PD's not on scene and said, hey, we've assessed the situation, you're clear to enter, you're not going on that scene, right? Because there's a chance that that person is still there, and if they're out shooting people up, hey, you might be the next victim, all right? A, you got to go home at the end of the day, and B, if the help gets hurt, we've got another patient, and you're not going to be any good to the patients who we initially got called out for, right? So that's a big thing for scene size up. Patient assessment, this is going to come with time. This is our critical thinking skills, right? How do we find our patient? What are they complaining of? When I ask them all of these different questions, what's their response? What do I hear when I listen to lung sounds? What do I feel when I touch my patient? based on their medical history, based on things I see on the scene, these are these puzzle pieces I'm getting, I'm putting them together, I'm doing my thorough assessment so I can properly diagnose and then properly treat my patient. All right, guys, you have a limited amount of drugs within your scope, but there are a couple that if you give them to a patient who doesn't need it or who can't have it, you can literally kill them. All right, so make sure that we're taking all of this information in and we are comfortable and competent with diagnosing with a patient with something, because if you diagnose them incorrectly and you give them a drug they don't need, they might be worse off than they were to start with. Okay, so we'll get to that point. Packaging, this is going to be like the lifting and moving chapter. How do we get them in the ambulance? Can they walk? Should they walk? Do we need to get a piece of equipment to have access to somebody on the 4th floor apartment with no working elevator? All right, that's another challenge that we have as EMS, as a first responder, that, you know, an emergency room setting doesn't. We actually have to physically take these patients out of the scene, get them onto the ambulance. And sometimes that's really hard. Sometimes you have a 600-pound patient who's on the third story apartment and we can't fit in an elevator, or the elevator doesn't work. All right, so that's another aspect that goes into EMS that most other healthcare providers don't have to think about. All right, so we talked about certification versus licensure for the state of Georgia. All right, there are certain requirements that you have to obtain a license, and we use those here at the academy, right? You got to be at least 18. You have to have a GED or a high school diploma. Immunizations, because guys, we're on the front lines, right? We come across all sorts of germs and cooties and just nasty, funky stuff. We don't know exactly what that patient has that we could get. So y'all have to have your immunizations to protect yourselves from contracting these different communicable diseases from the patients, right? Background and drug screening. Typically, the general rule of thumb for the state, because when you apply for the state, you have to do another background and drug screening like you did for the program. Any type of violent crimes, we don't allow into the academy or to have a healthcare license, because we don't want that to maybe happen with a patient or anything like that. And why do we need to pass a drug screening? Because y'all are around drugs in the healthcare world, right? So we just want to make sure that we're not having any maybe drugs go missing or any habits that might affect your patient, right? And then a valid driver's license. Why do you need that? Because you're going to be driving the ambulance, all right, a lot, right? At the most EMS services, you can call tech in the back of the truck with the patient for the duration of the call. But if that patient requires a higher level of scope, like say a paramedic, you're going to be driving to the hospital. All right. So we got to make sure that you're eligible to drive and that you're not going to wreck the ambulance the second you get behind the wheel.
Does it require any level of
Yes.
commercial licensure
So
to
you
drive it?
don't technically need a CDL for a normal grade ambulance. You will go through some driver's training if you get hired on here at Grady specifically, but no, you don't need any special licensure.
Okay.
Oh, yeah, I was just gonna ask if you go through driver training for this.
Yes, when you get, I can't speak for any other agencies, but I know at Grady, if you get hired on, you go through like a defensive driving course. We actually make you do a driving course with the real ambulance, all that stuff. So. All right, so again, you've got to successfully complete your course and have certification from registry to get a license in any other state or any state. You have to be able to physically do your job. All right, we're going to talk about that when we talk about EMS and the ADA, but you physically have to be able to do everything that your job is going to require you to do out in the field. And then again, guys, everything changes from federal level to state level to local level. So depending on what state you're in, if they have weird, crazy rules, you have to jump through those hoops if you're going to be practicing in that state. All right, so moving right into the ADA, guys, we are compliant. Healthcare is compliant with the ADA. EMS is compliant with the ADA, Americans with Disabilities Act to a certain extent. right? So this goes for anybody out there, anybody in this class. If you have any type of maybe like a learning disability or anything like that, or a diagnosis that would require you to say, maybe have more time to take a test or a more controlled environment to take a test, we can absolutely accommodate. Thank you. We can absolutely accommodate that. But when it comes to the physical part of your job, if you have any type of physical disability that prevents you from being able to perform CPR, right? We can't really budge on that in the healthcare field, because if you can't perform CPR in the class and I can't check you off as being certified, then you can't perform that on a real patient, and you are required to be able to do that for your job. All right, so with the physical aspect, we don't really have a lot of accommodations, but with the cognitive, we do. So if anybody in here falls underneath that, let me know. But healthcare and EMS is compliant with ADA. All right, so EMS really came about, guys, relatively, it's not that old, right? So with the Korean War, with World War, they were noticing that in these combat settings, because you'll notice too, there's a lot of similarities between military structure and EMS structure, right? If you haven't noticed yet, like via email, we go based off of military time in healthcare. So when that schedule says 0800 to 1700, that 1700 is 5 o'clock. All right, so you need to get used to the military time format. On your phone, in your car, on your TV, change it to the 24-hour format, because that's what we use in healthcare. Because true or false, outside of the 24-hour format, there are 2 8 o'clocks every day, 8 a.m. and 8 p.m., right? If you're communicating that like in a chart or talking over radio, which one do you mean? We don't really use AM or PM in healthcare. We use the 24 hours, so we know exactly what we're talking about when it comes to time. We also use the military alphabet, so be familiar with that. So if I say, the answer is D as in Delta, or Charlie, that means, C, D, Alpha, Bravo, all of that stuff. Be familiar with that as well. But we were noticing in the combat situation on the front lines that, yes, we had these doctors and these nurses, but we didn't really have anybody who was specifically trained for this on-the-spot, immediate, we have to make these decisions, we have to do these interventions out in the field setting and not in the hospital setting. So we started to say, hey, we probably should take these healthcare workers and kind of mold them and train them to be a first response mentality. And then that started to evolve into, hey, we can make this happen outside of a combat setting. And then EMS started really coming about. Guys, be familiar with these dates. Registry likes to know that you know these dates. Sometimes, especially this one right here, they'll ask you. But just to, again, to reference the early 70s, 1970s, was when we had like the first curriculum to really organize and standardize EMTs. EMS is a career, okay? It wasn't until 1971 that really the first textbook for this curriculum was even published. So depending on your perspective, we haven't been around that long in a structured, organized fashion, but we made a lot of strides since then.
So was it just like no emergency medical service?
So there was, right? Because Grady EMS has been around for 125 years. Like we literally would be horse and buggy. We would go do kind of like the house call emergencies, throw them in the back of the buggy and just take them to the hospital. But it wasn't until the 70s that everybody kind of started getting on the same page as to say, hey, we should allow this to be done, or we should take this approach, or we should have these policies or standards. So it was really more so organized in the 70s. Everybody good?
Yeah, AOS.
It's just the major publisher, I think American Orthopedic something. I can't think of it off the top of my head.
What's important about the orange book?
It was just this big publisher kind of started not monopolizing, but came kind of the go-to or the standard for the curriculum. All right, so again, we started to get a national standard in the 70s. We started advancing more so in the 80s to say, oh, hey, instead of just going on scene and grabbing them and throwing them in the ambulance and driving them to the hospital, let's actually start doing some interventions before we get to the hospital, right? Let's start giving medications. Let's start doing these things with a cardiac monitor. Let's start integrating advanced levels of scopes of practice so these patients can benefit. They can be receiving these treatments on the way to the hospital. So we're really utilizing that time of going and picking them up and driving them to the hospital. All right, so again, I kind of talked about it a little bit before, but we have a federal level, a state level, and a local level when it comes to EMS and healthcare and licensure, okay? And a lot of different laws and regulations, this is the same way, right? The nation can have one law, but then the state can say, well, I don't really like to do it that way. I'm going to do it my own way. And then you can have, like, the governor can say that, right? But then you can have a mayor of a town be like, well, I know the state does it this way, but we're going to do it a little bit differently. Okay, so that's the same rule of thumb when it comes to thinking with EMS and healthcare in general. So the federal level, what's going to be the federal level of protocols and standards when it comes to EMS? Registry, right? The national registry at a national level, they're going to say, okay, I accept that if you pass these tests, you're competent and you can go do whatever you need to for your own particular state. All right, so when we get to the state level, so for example, Georgia does not require you to take an additional test, right? But Florida does. There are actually, I believe there's still 2 states that don't even acknowledge the AEMT scope of practice yet. They say, nope, you're either an EMT basic or you're a paramedic. There's no in between here in Montana. I don't know if that's the right state. But the state can say different things. Hey, you're going to get a license in our state. You got to play by our rules. All right, there's different regulations. And then we have a local level. All right, guys, this is probably going to be the utmost important level for you guys to understand and keep in mind working as an EMT, working as an AEMT, working as a paramedic. All right, so what do you think the local level is? Okay, so maybe county, or for EMS, it is whatever service you work for. So there are different local levels and rules for grade EMS. There are different local regulations and protocols and standards for AMR, for Central, for Metro. All right, each different service is going to be designated differently based on who? Your medical director. All right, guys, because once you get a license as an EMT or as an AEMT or as a paramedic, when you go to apply to these different services to work for, so let's say you come and apply for Grady EMS, there is a medical director. In our case, there are 2 medical doctors who oversee all of the things that they say you can and can't do. You are working underneath their medical license when you get hired on with that service. All right. So these doctors who are kind of taking you guys under their wing and covering you underneath their medical license, they make up the different rules. All right. So our medical directors at Grady tell us exactly what drugs we can do. They are the ones who come up with all of our protocols. So if I respond to a patient who's complaining of chest pain, all right, what all do you think that could be?
Possible heart attack.
Okay, so the first thing that we're going to go to is, hey, this could possibly be a heart attack. Let me do some different tests and see if that's what's happening or if it could be something else, because it could be heartburn, right? It could be all sorts of other things. It could be like a strained muscle or something like that. So,
And also an anxiety attack or something.
I'm sorry?
Or it could be like a panic attack.
Yeah, it could be an anxiety attack. It could be maybe some hypoxia because we're hyperventilating. We'll get there. But yeah, so my protocol working at Grady for chest pain is to say, hey, I need to get a 12-lead EKG. I need to put stickers on this patient's chest and send it off to somebody who can interpret it to see what's going on. And if we're having some cardiac involvement, I can give these drugs. I'm going to give 324 milligrams of aspirin. I'm going to give 0.4 milligrams of nitro, and I'm going to put them on oxygen depending on how much they need. If you're at a paramedic level, if that nitroglycerin doesn't manage the pain, I can give fentanyl to manage the pain. All right, those are my local protocols. Tells me exactly what interventions I can do and what drugs I can give. The medical director decides exactly what those protocols are. So for example, at a national level, again, I can handle hundreds of drugs. State of Georgia takes away some of those drugs that I can give at the national level. They say, well, we don't really think that it's appropriate that you give it, so we're going to take away, let's say, 50 of those drugs. All right, so at the state level, I can handle almost 300 drugs. But at Grady, my medical director says I can only handle like 50. All right, so my medical director is going to be at the local level. They're going to further make different decisions about what we can and cannot do if you work for that particular service. All right, so for example, as a paramedic in the state of Georgia, I can give medications to patients that can temporarily paralyze and sedate them. If I think I need to stick a tube down their throat or something like that, but they're still awake, and I can't really do that on somebody who's awake, I can push those drugs and I can say, night, night, here we go, we're gonna put this tube in. I can do that at a state level. I cannot handle those drugs at Grady because my medical directors say, well, you know what? We are not really ever more than 10 minutes away from a hospital in Grady's jurisdiction, right? We're lucky we're in a metro setting. We are very close to several different hospitals in the city of Atlanta. Guys, those drugs can be very dangerous if I don't do them correctly or if I give too much or too little. So they say, because we're not really that far away from hospitals, it's not really necessary that you push those drugs or do those interventions. So they make those changes based on the area that you're serving, the patient population that you have, the resources you have available. All right, that's going to be your biggest one to understand. Federal is national registry, state is going to be Georgia, Florida, Tennessee, whatever. They make their own kind of accommodations, and then at the local level is going to be everything that you need to know because those are your protocols for whatever service you're working for.
So like, if I understand that if you like do something against you that's not in your realm in like a state or a federal level, you could definitely lose your license or certification. But if you do that at a local level, like what happens?
So guys, what do you think? Is it an easy feat to go get your medical license? No, it's a lot of time, it's a lot of effort, it's a lot of education, it's a lot of stuff involved. So these medical directors don't take it lightly. If you're operating underneath their license and you do something that they tell you you can't, they're gonna be like, whoa, dude, you're a liability because maybe you did something you weren't supposed to and you killed a patient. I am not going to have you associated with my medical license if you're not acting by protocol. You have grounds for a lawsuit if you cause harm to a patient because you are not acting within your protocol, and you're probably going to get fired because they are not going to want to deal with a wild cowboy like you. So yeah, you're susceptible to lawsuits and definitely being terminated.
Okay.
Everybody good? Guys, it's also important to remember too, medical direction is going to be y'all's safety net, okay? Because let's say you're working at Grady and you have a patient and you've done everything according to protocol, and based on your judgment or the patient's reaction to that treatment, you think that they could benefit from something that you're not technically supposed to do according to your protocol. Let's say you've given the max amount of drugs that you can give a patient, but you really think that they need more of it, but your protocol says you can't give any more. What can you do?
Follow
You can
protocol.
reach out to your medical director.
Yeah, so call medical control and say, hey doc, this is so-and-so, you know, this is what's happening with my patient. This is what we've already done. This is why I think that they need something that we technically can't give, and they can give you permission to go outside of your protocol. Now remember, if that happens, what information do we need to get?
signature or something.
That doctor's name, right? Okay, can you spell out your name, Dr. Anschbacher? Because you are going to chart and say, hey, if anything bad happens to this patient, it's because Dr. Anschbacher told me to do it. All right, because doctors have a much higher scope than we do, than y'all will as EMTs. So they can kind of like override protocols, but you definitely need to get the information as to who you talk to. Because if something bad happens, it's no longer on you, it's on Dr. Anschbacher.
There's
Okay.
a shared responsibility there, right? Because
So yes, there is, and we'll talk about that when we get to the communications chapter, but yes, if that doctor's telling you to do something that you think is gonna kill your
vice versa,
patient,
right?
yeah, then you can say, okay, Dr. Anschbacher, you're telling me that I need to do this. And if they're not like on scene, then you can say, I don't feel comfortable doing that. But yeah, just because somebody tells you to do something doesn't mean you need to follow through with it. You need to be a patient advocate, which means that you need to kind of stick up for your patient and say, I know you told me to do that, and I know you're a doctor, but I don't think that's going to be best for patient, and we can figure that out on a case by
So it's
case.
kind of a boots on the ground.
Yes, more so, yeah.
Is an epi applicable to the scope practice?
Nope. Y'all can handle epinephrine through an EpiPen, which is one of the drugs you can kill someone with. So
And like medical control can only like allow you to go out of the scope on like the local level, right? Or can they like tell you can go?
if you have the drugs in your truck, or if you have the equipment in your truck and they tell you to do something, you technically can do what they tell you to.
I mean, it would make sense that they could operate anywhere within the state level.
Yes,
They have the authority to do that.
to a certain capacity, yeah. All right, guys, medical direction is also going to be your safety net. If you're questioning anything, be like, hey, I'm not really sure what's going on with this patient. You can call medical direction and say, this is what's going on. How do you advise? Right? So they can be your safety net. If you're questioning anything, just get a second opinion. Guys, a lot of times medical direction is going to be very cautious about giving you orders to break your protocol. Because where are they? They're at the hospital, right? Or you might call, I might call Dr. Kumar. I've got her personal cell phone number, and she might be sitting at the pool, with her family. She's not where with the patient. She's not in front of them, right? She's not actively listening to lung sounds or looking at the patient. So most of the time, you will get the medical director to say, hey, can't really give you 100% answer on that. Why don't you just hold off until they get to the hospital? Okay. Maybe we could FaceTime them. Maybe we could incorporate something else. But a lot of times they're going to be very cautious, because if they say, yeah, sure, go ahead, and they haven't physically assessed the patient, or they can't physically see the patient, if that treatment that they give you permission to do kills the patient, it's on them, even if it was just a phone call conversation. It doesn't matter that they weren't in front of them. So you will see sometimes they're very hesitant to give permission for these requests, because it's ultimately on their license if it causes harm. So this is just a little diagram as to how everything works together. We have to have these regulations to make sure that we can function at a state level, local level, all that jazz. All right, so we will go all over this on your BLS day. This is included in your scope of practice. CPR stands for cardiopulmonary resuscitation. You get to use a machine called an AED. With that act of CPR, it stands for an automated external defibrillator. This is within your scope. Also, people who are not healthcare providers, all right, Joe Schmo who works across the street at Publix, they might be CPR certified. Okay, there are millions of what we call lay people. When we use that term, it's just going to be someone who is not educated or licensed in the healthcare field. It's just like a civilian, if you will. There are hundreds and thousands and millions of lay people who are certified in CPR. All right, so they usually will help you on scene. Sometimes they can hinder your patient care, but just be aware that it's not solely exclusive to just healthcare providers to be CPR certified. All right, which brings us into the Good Samaritan laws. What do you guys know about that?
Basically, if you're like certified in CPR, or if you're like on the phone with 911 and they're giving you directions on how to do it, you have to use your best judgment to like help. And as long as you're trying to help the person and they're unconscious, you gotta do what you gotta do.
Okay, so yes, if you are somebody who doesn't know any better, or who's, you know, acting in the best interest of that patient, or you're listening to dispatch's instructions and you're trying to help the patient, you're usually exempt from what? Lawsuits, liability, right? Because guys, there are some injuries that we can cause in the act of trying to help people. So if this Good Samaritan covers these lay people who don't know any different, who are come across somebody, they fell out on the sidewalk, they had a syncopal episode and they're not breathing, they call 911 and that dispatcher tells them, hey, I need you to do CPR. And they've never taken a course in their life. All right, if they are doing what dispatch tells them to and they're trying to help that patient, if they cause an injury, then they're not gonna be kind of eligible for a lawsuit from that patient or the patient's family, right? Right now, y'all are covered with Good Samaritan because you don't know any better yet, right? You haven't gone through this course, you haven't been taught the right way to do things, but that is going to change once you graduate this course, once you get your CPR certification, right? Because once you guys know how to do it correctly and you're certified with CPR, if you come across that person on the sidewalk and you're doing compressions in the totally wrong spot, like you're doing compressions down here instead of up here, and you cause harm to that patient, you like rupture an organ or something like that, because you have been trained in the right, correct way to do it, you are eligible for a lawsuit because you know better. All right, that's why a lot of times if you hear like on a plane or somewhere in a public setting, hey, we have a medical emergency, do we have any healthcare providers? Do we have a doctor? Do we have a nurse? Do we have an EMT that can come help? You might think it's really, really crappy for these doctors or nurses to do it now, but they might be like, ooh, nope, I'm off duty. I'm not gonna get caught up in that. Because if they go over and they help and because guys, I promise you, if you don't know already, you will once you go through this course. People out there these days are sue happy. All right, you've heard the term trigger happy? People are sue happy. They will sue anybody for anything at the drop of a hat, and that includes people who are trying to help. So that's why you might see people kind of who are a doctor or a nurse kind of say, no, I'm not working today, because they don't want to go get involved, have an injury or something occur, and then be eligible for a lawsuit, because we're not covered under Good Samaritan, even if we're acting off the clock. Okay.
Like why? Because like if we're doing everything correctly, and like you can still break a rib during CPR.
Right. Now, if you're still doing everything correctly, you did not do anything outside of what you were trained or the correct way to do it, you still can cause harm, which is true. That you're exempt from a lawsuit with that. But if it can be proven that you were doing it incorrectly, or you didn't have the best interest of the patient in mind, that's where we are not covered by Good Samaritan. So you got to be on point. You got to know what you're doing, and make sure you're doing it correctly, so you are covered when it comes to lawsuits once you get this education under your belt.
So what kind of insurance do first responders carry to protect themselves?
Mm-hmm.
I mean, I worked in the chemical industry for a long time, and a long time ago, chemical plant managers, right? I mean, you weren't held responsible, but today's world, you absolutely can.
Yeah. So again, guys, each service, like Grady has a really great legal team that if anything comes about from a lawsuit, then they go through the charts with a fine-tooth comb, any evidence they might have, and they keep us out of the courtroom most of the time. You do have the option to purchase your own kind of malpractice insurance as an EMT, as a paramedic, as a doctor, and it covers you up to a certain monetary amount. But typically you don't really see that being purchased until you get to the MD level. But it is an option that you can purchase it.
Like an umbrella insurance when my kids were young.
Yeah, pretty much. Pretty much. All right. So guys, we broke down the hours. If you want to know the exact hours on your schedule, there's 3 different columns that tell you the hours of classroom time, the hours of lab time, and then the hours of clinical time. So around about 150 hours are usually what an EMT course entails. Again, we're training you to have the knowledge and hands-on application of everything that we do in this course. Moving into the AEMT level, we kind of already talked about this. Again, you get to put the needles into patients to give fluids and medications. You get to handle more drugs, more advanced airway management. Paramedics, again, the top tier, again, up to like 1,500 hours in the classroom, 700, 1,000 hours of clinical time. More responsibility, more clinical time, more classroom time. All right. So guys, questions, comments, concerns so far? Everybody okay? Everybody good? Everybody on Zoom okay?
So far.
So far. All right.
Yep.
So again, guys, a system. All right. Healthcare, yes, there are different components, but as first responders, there are so many different things that people don't even think about that go into our ability to actually arrive on scene and take care of these patients. All right. Be familiar with all of these. We'll go over them briefly, some more than others. All right. But there are technically 14 components of the system. We'll talk about these individually. Little diagram to see how we all work hand in hand, right? All right, so the first system is public access, right? What is this? 911, right? People take it for granted, guys. 911 hasn't been around the entire duration of humanity, right? It used to be if you had an emergency, you were just screwed. You could try, if you memorize the local police department, you could call them. But now, all across America, if you pick up the phone and you dial 911, it connects you to who? A dispatcher, all right? These dispatchers are trained to handle these situations. We'll talk about the different kind of levels of dispatchers because that's evolving as well. But anytime you pick up the phone, you get connected with a dispatcher. And when you call 911, you get connected with a dispatcher. All right, it goes through several steps. What county are you in? What area are you in? That's going to direct you to who picks up the phone, right? Then they're going to ask you, okay, is this a medical emergency or are you getting robbed? What resources do you need? Do you need police? Do you need fire? Do you need EMS? Based on that triage, they're kind of prioritizing that information that the caller is giving them. Then it gets tiered down to that specific department. All right, is this just a robbery or has somebody been shot during the robbery? Okay, if it's just a robbery, let's knock it off to APD. If somebody got shot, APD and EMS gets it, and probably fire as well, because they co-respond a lot with these medical emergencies or these trauma situations. All right, so again, the ability to just pick up the phone, dial 911, and be connected to the appropriate resources is vital, right? Because if somebody calls and we don't know there's a medical emergency or where it's at or what to look for, we're not going to show up, right? Here at Grady, and really starting to catch trends across the country, we utilize, instead of just plain old dispatchers, we utilize EMD. What does that stand for? Emergency Medical Dispatcher. All right, so if you're going to get hired on to work as a 911 dispatcher here at Grady, we have higher standards. You are going to go through, I believe it's a 6 to 12 week, don't quote me exactly, course on how to better handle medical emergencies. Because if you talk to just a straight up dispatcher, what are they going to say when you call the phone? When you call 911, be like, oh my gosh, they've been shot, there's blood everywhere, send somebody quick. Back in the day, or at specific services, what are you going to hear on the other line? Okay, what's your address? All right, I can help with that. I've dispatched EMS, I've dispatched police, and now I'm just going to sit here on the phone with you and give you the best of luck, and hopefully you don't die before they get there. All right, that used to be what it was, but with an EMD, they will actually be trained to ask different questions. Well, how much blood is there? What color is the blood? All right, what does the patient look like? Okay, I need you to do these steps to apply pressure to try to stop the bleeding. Do you have a tourniquet or a belt handy? Can you place it there? Make it as tight as you can. They give you very detailed instructions to try to provide some type of medical care before we arrive on scene. All right, this includes instructing people how to perform CPR. All right, you might not know anything about CPR, but if you call 911 and say, hey, this dude is blue, he ain't breathing and he ain't moving. Okay, sir, I need you to place both of your hands in the center of his chest and push hard and fast. They will talk you through CPR. They'll make you count out loud. They'll give you step-by-step instructions. All right, we utilize these at EMS or at Grady, and it's tremendously helped in patient outcomes, especially like with bleeding control and CPR and stuff like that. So again, guys, the communication system, these dispatchers are sitting in a room with a crap ton of computers in front of them. There's different channels, if you will. If you first call 911, they get your address, they get all the information, they dispatch the crews, and then they send you to another dispatcher to get more information. All right, their job is stressful. I wouldn't want to deal with their job, just like they probably wouldn't want to deal with our jobs. But there's a lot going on when it comes to communicating the right information to us, telling us where to go, what to expect. Because when do you think our scene size up starts?
As soon as you get the call.
When the call drops, on the way to the call. All the information that we're getting from dispatch is going to help, because they're asking, well, how many patients are there? What kind of situation is this? Is there any smoke or gas leaking from the car? Okay, they're giving us information to go ahead and say, hey, your scene is safe. Hey, your scene is not safe. Hey, you've got 20 patients. You got 1 patient type thing. So clinical care, guys, this is just going to be when we utilize the different pieces of equipment when we're taking care of the patients. This is kind of a broad terminology. It just makes sure you're familiar with your truck, with your equipment, with your location, all that jazz. Human resources, HR, what is this? Every agency has one. You say something inappropriate, or you offend someone, or you're not conducting yourself in like an ethical manner, HR gets involved, make sure that we communicate well, that people are reprimanded, that we go on not offending people. Yes, we do deal with HR if you go out there and do something stupid, right? But we don't really see them day in and day out on the EMS aspect, just because they're part of just like an administration level of different agencies. I already talked about the medical director, okay? We will go more into different types of orders that they can give and protocols that they provide, but this is the person who says, hey, if you're working here at Grady, I'm deciding exactly what you're doing and not doing, okay? We can use them as a safety net. We can call them and say, hey, can I do something extra? Or, hey, can I get some advice? All right, gotta know the difference between offline and online orders. All right, what are offline orders?
They're actually, I guess you're under like some kind of supervision, and it's what's expected this already expected of you when you're in the field.
Right, they are your set protocols. They are already made up. They're already decided on. If you come to Grady, you'll get handed a protocol book, and they're literally on paper. This is what you do if you respond to a chest pain call. This is how you handle a cardiac arrest. This is how you handle difficulty breathing. All right, they're already made up. They're already determined by the medical director, and they will vary from service to service. All right, what is an online order? This is the extra.
They are the direct orders that are given per situation.
Right. So these are going to be case by case scenario. You're going to be like, hey, I've already gone through my protocol for chest pain. This isn't really helping. I think I need to give more of this medication. But technically, according to my protocols, my offline orders, I can't do that. But this is when we pick up the phone, we call the doc, and we say, hey, can you give me permission to do something that's outside of protocol, or something extra, or something different? All right, so offline is already there. It's already predetermined. And then that online is that extra permission we can get or obtain from the medical director. What do we always get when we get an online order? The name of the doctor you talk to, because that liability will go directly on that doctor and go off of you if something bad happens. So guys, just know that these exist. We don't really see them again at our level. The higher up admin, the scheduling, people who determine how much money we can spend, if we get new ambulances or new equipment, all of these things have to go into play to make sure we do have what we need to do our job, right? But we just don't really interact with these people on a day-to-day basis. So legislation, regulation, people who keep the trucks running, all that stuff. All right, integration of health services. So guys, the healthcare and the communication and providing for these patients doesn't stop when we are done with the interaction, right? Where does it continue? Where do we usually take these patients?
To the hospital.
To the hospital.
ER.
Right, to the ER. So we definitely have to make sure that we're keeping a good relationship with these doctors and these nurses, right? That professionalism, being tactful, which means watching what you say, can actually, in the long run, harm a patient, right? What if you come into an ER one day and you're just pissed off, you've had a bad day at work, you got people calling for stupid stuff, you haven't had lunch, and you come into the ER and you talk to a doctor and you smart mouth them. You go off on them, you get an attitude with them, okay? If that doctor reciprocates that energy he's getting from you, he's gonna say, well, screw you, you stupid little EMT. You don't know what you're talking about, and you're on my list. All right, guys, most of the doctors are not like that, but there are a few. There are some nurses who are like that. There are some paramedics that are like that, okay? So what happens next time you bring in a really sick patient, all right, and you're interacting with that same doctor or that same nurse or that same medic, and you come in, you've already had a bad interaction, and that doctor's like, oh, this stupid idiot, come in here again. They might just discard everything that you say because you've pissed them off or you have, questioned their competency or whatever it might be. And because they're pissy with you, they might not do that test on that patient, or they might not believe that you saw what you saw or you heard what you heard, and they might neglect that area of patient care, and that patient can suffer because that wasn't done because your interaction with the staff in the hospital. So just make sure everybody's on the same page, because at the end of the day, at the end of the interaction, what's our concern? The patient.
The patient safety.
Right. Scene safety, yes. But the patient, you have to be a patient advocate for every single patient you have, which means you have to speak up for them, right? Especially if it's an elderly patient or a pediatric patient, a little person who can't really stand up for themselves. We have to stand up for them. So if it's something that we really, really think needs to be done and that doctor's not really listening to us, be like, hey, doc, in a tactful, professional way, we can say, I really think you need to take a second look at this or that, because we need to make sure at the end of the day, the patient is well taken care of, okay? So we take different types of patients to different hospitals, all right? If you're having a heart attack, there are certain hospitals that if I take you there, your outcome's probably gonna be great because they deal with it day in and day out. They have experience and they have the equipment they need to treat you. All right, same with trauma. If you're really, really, really badly injured, where do you need to go? A trauma center, right? That means we have people who see these injuries day in and day out. They have the equipment, they have the resources, and they have the capacity. All right, so strokes, burn patients are another one. We take them to designated facilities that can handle that patient, all right? It might be a longer drive. It might be a hospital that you don't like going to, but at the end of the day, we care about that patient's outcome. So we'll talk a little bit more about this later on, but know that we have systems in place in specific hospitals. We take specific patients if they're having these issues. Everybody good? Yes.
Do we take into account the patient's insurance and what's in network for them?
Not in an emergency setting. No, it is against the law for any hospital to refuse treating a patient if they are having an acute life-threatening emergency because of insurance. Once they stabilize them, and anything after that can be an insurance loophole, but if the patient's truly having a life-threatening emergency, we don't care about that.
Also for pediatric patients, I feel like we'll probably talk about this later, but like, is it more important to advocate for like the kid or for what the parents want for the kid?
Good question. We will talk about it, and I think in the upcoming chapter. But again, we're a patient advocate, so there are some legalities where minors fall under the care and decision-making skills of their parent usually, but we can sometimes very strongly persuade something different or step in and say, no, this is not the way it's going to go. All right, guys, we have something really cool. We have a lot of cool things at Grady, but one of the cool things is we call it MIH, Mobile Integrated Healthcare. Is anybody not from Atlanta or isn't really familiar with Atlanta location, economic levels, all that stuff? Okay, no, that's fair. So guys, we have a very big population of patients in the Grady area, in the city of Atlanta and Fulton County. A lot of those patients, again, we talked about before, will call 911 for something that we don't deem a life-threatening emergency. They ran out of medications. They need to make a doctor's appointment. They, they couldn't get to their treatment because they don't have a car, they don't have transportation. So now they're having complications because they didn't receive that treatment and they need to go to the ER. We have a lot of that here in Atlanta. All right, so these patients have no other choice or no other knowledge than to call 911 for these non-life-threatening emergencies, right? That takes away, if I'm responding to somebody who stubbed their toe or somebody who needs to get their prescriptions refilled, I'm not there to respond to somebody who just got shot or somebody who is having a heart attack, all right? So these people who call for these non-essential really reasons kind of take away from why we're here, right? We're here for immediate life-threatening emergencies to get you to the hospital to hopefully make you make it out alive, right? So what we did with the Grady is we kept track of all these people, because guys, we lovingly call them like their loyal Grady customers, or the not so nice term is frequent flyer. I guess there are people who will call 911 multiple times a day, like up to 4 and 5 times a day, 10 times a week for these non-essential, non-life-threatening issues. So we compiled all that information. We started tracking who these loyal Grady customers were, and we were trying to find the reason, why are you calling 10 times a day? What do you need us for? All right, so if we can determine, oh, well, Mr. Jones calls 5 times a week because he can never get to his dialysis appointment. All right, then we will go out to Mr. Jones. We will have a PA, a physician's assistant, or a nurse practitioner on board, and we will have either a paramedic or an EMT. They'll go out to Mr. Jones's location and say, all right, Mr. Jones, we need to make sure you got your transportation set up. All right, we're making sure that so-and-so is coming to pick you up to take you to dialysis so you don't miss that treatment, so you're not calling 911. Or we'll go out to, Mr. Brown's house, because he calls all the time because he always runs out of his meds. Well, because we have an NP or a PA, they have the ability to write prescriptions. So we go out to Mr. Brown's house and say, all right, I'm calling in these scripts. I'm going to make sure you get these prescriptions. You're not going to run out of them, so you're not going to need to call 911. So as we're going out to these people's houses in the community and doing kind of like a community paramedicine to deal with the underlying issue to help avoid, obviously, guys, if they're having a life threat, they always call 911, right? We encourage them to. But if they're tying up these trucks with something that we can help kind of redirect, that's what we use MIH for.
That's totally cool.
Yeah, it's really awesome. But yeah, so that kind of takes away a lot of the, okay, well, let's get in the back of the truck, let's drive you to Grady so you can get your prescription refilled. So it takes away a lot of that.
Do you have dedicated teams then that do specifically that?
Yes.
I mean, that's amazing.
Yes.
Resource allocation.
Yep.
How many people would you say like do that kind of thing? Like the
much more than you would think.
Like estimate like, per week.
Yeah, close to hundreds.
Is it over 50% of your calls?
Maybe not the same repeat offenders, but the same, hey, I ran out of meds. Hey, I can't get an appointment. Hey, this. It's a lot of the reasons are the same. Yeah.
That's a really good use of data.
Yeah, it's awesome. So again, we talked about that. They can write prescriptions. They can set up transportation. They can call in, they can even call different clinics and doctor's appointments and make appointments for them, type thing. Evaluation, we have the medical director will ultimately decide, hey, if you violate a protocol or you did something just crazy stupid, they're the end all be all decision as to whether or not you keep your job. But we have a department in place to hopefully prevent you from getting there. Is the QA or QI, quality assurance or quality improvement. They are actually in this building. Their offices are up front. They go through all of the charts that everybody submits and they say, okay, this one was charted as a chest pain. They go through the chart and make sure that everybody's following protocol. If they're noticing that, hey, why did you do this? This is not in protocol, and you don't have your documentation in check and you're not giving them a valid reason why you kind of did something or didn't do something, they'll send you an email. Be like, hey, we need to talk about this chart. You need to make sure that you're reviewing the protocols and you're not doing this again, to try to prevent you from going to court in a lawsuit and to try to prevent you from getting to the point where you're killing or harming patients and losing your job. Okay, so that's a big part. Especially bigger EMS services have a really good QA, QI department. The smaller ones, not so much, but that's the beauty of getting on with a bigger service is you get a lot more support from things like this.
It's kind of like real-time coaching. I mean, do you guys
Yes.
have like
We have a protocol system.
somebody and they say, hey, look, so how's it going?
Not unless you're being problematic.
Unless, okay, so
If you don't ever hear from QA or QI, you're
you're
good.
good to go.
You're not killing patients. You're not doing things that insurance doesn't like to see. You're doing things appropriately. But if you are hearing from them, then you're not doing things correctly.
Is it ever kind of like, hey, we kind of noticed that every chart you have already respirations of 16 and something.
Yes. Yes, they will pick up if you're being lazy in your documentation, if these timestamps aren't matching up, if the vitals, if you're saying somebody's got a pressure of like 50 over 20, but they're sitting upright talking to you, having a conversation, they'll be like, let's go back and make sure that we're doing this. Yeah. Information services, these are specifically people who work for Grady. They're based out of the main hospital. My mom actually does this for Grady. Different like trauma registrars, they will look at, there's different teams that assess all the stroke calls, the heart attack calls, and they'll say, all right, what was our on-scene time? What interventions did this patient receive in the field? And they'll actually follow up with these patients and say, hey, did that intervention help the patient in the long run? Is there something we could have done better? Because guys, we are evolving tremendously in healthcare and in EMS. It used to be in the 70s and the 80s and even in the 90s, it was like the wild, wild west out there, right? It was cowboy mentality. We just went out there, we did what we wanted. We didn't really ask for permission. We did just some of these crazy things. But now EMS is very much research-based, all right? And every single one of you will contribute to the evolution of care and protocols and treatment based on your documentation, right? If you're not documenting that you placed a patient on a backboard, it's not going to get put into that, okay, let's follow up, let's see if this helped, let's see if it hurt type thing. So every one of you guys are going to be involved in research because there are people who look at the things we do in the field and how the patient outcomes are changed from it. And then they'll put together and they'll say the study, be like, hey, we don't really think backboards do anything for patients, or we don't think that we should use this protocol anymore based on the research through years and hundreds and thousands and millions of charts.
Are EMTs or paramedics expected to participate in research like doctors are?
It depends. Grady is a huge research educational system. So they're we get pieces of equipment a lot of times that companies want to see if they work, or, you know, trial stuff, and we'll have it in our junk bags and we'll be instructed to do it and use it and report back on it. But it's never anything like they come up to you and be like, you have to do this or blah, blah, blah. But we're integrated in it a lot, especially at Grady.
Is everyone responsible for writing up a report, or is it just one person dedicated to it?
If you are with the patient for the duration of the transport, you're writing a chart. If you come on scene and you're helping the patient before somebody else gets there, but you had interaction and you treated the patient, then you're going to chart what you did with the patient while you were with them. Yes.
So everyone that interacts with the patient has to write some level of report.
To a certain extent, yes. Or they're included in somebody else's report from that patient interaction.
Is that a standardized digital format that you guys use here, or is it?
Grady, yes. Georgia, more so. There are still significantly rural areas that I do believe still use paper chart, but that's something that's almost unheard of these days, but it does exist still. All right, so financing again, guys, just depending if it's a privately funded agency or if it's like a county or government funded, you're gonna get more resources. You'll have better equipment. You'll be able to have more vehicles purchased, all sorts of stuff that goes into that. Again, we might see the repercussions of not having appropriate funds by not having trucks that work or not having equipment that works, but we're not directly involved in that. The best that we do is make sure we're documenting appropriately, right? Make sure that if these patients have healthcare insurance, we're getting that information, we're documenting that appropriately, because if it's charted appropriately and it sends off to insurance, then insurance can pay the cost versus, you know, the company just eating the loss type thing. So it's not something you guys really think of when you go into EMS or healthcare, but insurance does play a lot into it when it comes to finances. So that's another thing that QA or QI will send back and be like, hey, insurance doesn't like to see that you did this because this patient, you know, had this issue or this ailment. So they'll tell you, you know, fix this for Medicaid patients or Medicare, whatever. So again, making sure we get those signatures from patients, we're charting insurance appropriately is how we can contribute for the finance part. Education, so this is just, you got to have people train you to do stuff so you can get certified and get your licensure. This is us, this is the staff at the academy. Any other academy that has EMT courses or paramedic courses, we have standards we have to follow. We have certain continuing ed that we have to get as instructors type thing. We have to incorporate different ways that we teach you guys, the hands-on, the cognitive, all that different thing, or those different things. We have to be a paramedic for the most part. Any type of like program director has to have a college degree, have to have experience, and we have to do well with our job, or we don't continue to do our job. All right, so prevention and public education. What do you think this is? How do you think we're involved in prevention and education? What all can we do as an EMT?
Workshops.
Okay, so maybe workshops. We don't really see that a ton. There are certain places that can say, hey, every Friday we'll have a $5 CPR class. Come on in, we'll teach you how to do CPR correctly. All right, what else? What else do you hear when it comes to first responders as a whole? The fire, PD, and EMS. What do they do for prevention?
Community outreach.
Okay, so community outreach, how?
I know when I was a kid, I went to like a couple fire stations, like a class field trip thing, and my health teacher was like taught me CPR,
Okay.
and then she taught all of us.
So field trips, right? My husband loves/hates these at his fire station. They call it touch a truck. They'll have all the fire engines out, and they'll have the EMS company, and they get to see it, and that they teach them the stop, drop, and roll, and you know, just the first aid stuff. What does PD do?
dangerous.
We don't like it, but they enforce prevention and stuff.
Yeah, gun safety.
Okay, so they can maybe do gun safety classes, but we might not like what? Traffic, maybe getting arrested, maybe getting a ticket, right? If you get a ticket for speeding, if you get a ticket for not wearing a seatbelt, they're trying to prevent you from, you know, doing that in the future, because we know excessive speed and not wearing your seatbelt can literally kill you. So
Right.
let's try to divert that by making you pay money. All right, you might hear fire departments, they or police stations, if you have a car seat, you can come to their station and they'll make sure it's installed correctly. Or they might give out free helmets to kids to say, hey, you need to wear a helmet when you ride a bike. All right. We don't do a ton of that community. Let's teach initial like information, but we have a lot of what we call teachable moments with our patients, right? Going back to those non-essential reasons that people call 911. All right, if we come on scene and somebody is like, yeah, you know, I stubbed my toe on the coffee table, or I've got a stomach ache, or I've got this or that, we have to be careful the way that we do this, right? But we can say, hey, I'm on the clock. I get paid regardless. If you want me to take you to the emergency room, I will love to do so. All right. But, you know, you're not dying. We'll do an assessment, of course. We'll make sure the vitals are good, that we don't suspect anything else is going on. But we could say, you know, this isn't really a life-threatening emergency. Is there any way, maybe you can call your doctor and make an appointment, right? Maybe we can take you to like the clinic down the street instead of taking you to the emergency room. All right, we can give them some education to say, if this happens in the future, there are different ways that you can maybe take care of it, right? We have to be careful for a couple of reasons when we're talking to patients about this. Why? What's one of them? Yeah, they can get offended. We have to be non-judgmental, purely educational, and say, hey, you know, black and white, this is what's happening. That's not, you're not dying, and here's another option. Sometimes it can come across, especially if you've had a bad day, or if you're just not socially aware of the way that you interact with people, as being judgmental, right? And, you know, belittling these patients. Well, you idiot, you just stubbed your toe. Why are you going to the emergency room? You're not dying. You know, somebody just got shot. Now I'm over here taking care of your pinky toe, right? That's not how we educate these patients. And then also too, what might we run the risk of if you're like, dude, you're fine, you don't need to go to the hospital? Liability, right? What if they're saying that they have a stomach ache, they just ate a Big Mac and we think that they ate too much, but they're really having a heart attack. And we're like, dude, you're fine. Don't go to the hospital. Don't call me again. Okay, because that's happened before. And that is why we have to do a thorough patient assessment and then use our judgmental skills to say, hey, we've got other options here, or yes, I do think you need to go to the hospital. Okay. So just again, some different ways that we do preventative and educational purposes in the first responder community. We talked about research. Again, guys, you're involved in the research, right? We're not just saying we're going to do this because we've always done it. We're going to throw everyone on the backboard because it's just what we've always done. All right. We're coming to find that backboards are not always a good thing. Those are the really long, hard boards that you put somebody, you lay them flat so they can't move. Unless they actually need it, we don't need to be using them anymore. All right. Based off of research at Grady, there is a very strict, you have to check some of these boxes to be put on a backboard. Otherwise, we're not going to put you on it. Has anybody ever been on a backboard? All right. Comfortable or not comfortable?
No.
Very uncomfortable.
Very uncomfortable, right? These people are laying flat with all of their body weight, pushing them up against a hard surface. If they don't absolutely need to be on that backboard, we can actually cause injuries from them being on that backboard. So all this research and following up with these patients and seeing, hey, does this help or does it hurt, is evolving to say, hey, unless you fit this very small criteria, we're not putting you on a backboard anymore. That was unheard of 10, 20 years ago. What? No, everybody gets put on a backboard. No, actually, based on research through your documentation, we're finding that no, it's not a good thing. All right. So yes, there are some people who absolutely do need it, and it's beneficial for those set parameters, but for the most part, we're moving away from the backboard in EMS, okay? And that's just based on the drugs we use in EMS and the protocols we use in EMS. A lot of things are changing because we're actually, evolving. We're not just the crazy cowboy part of healthcare that a lot of people still think we are. We actually are, we're growing up and getting sophisticated and basing our stuff off of research. Everybody good so far? Okay.
They keep a sweat factor on the training?
Nope, not unless you're like high terrain extrication stuff. All right, so roles and responsibility of y'all, okay, as EMTs. All right, you're gonna be highly responsible for making sure that your truck is working, that you got gas, that your AC, that your heat, that your sirens, your lights work, that all of your equipment is stocked and functioning, okay? That's a major part of your job. A lot of times the companies will consider you an EVO, emergency vehicle operator. So if you're not the higher ranking person on that truck, like a paramedic, that truck's your responsibility. Make sure there's air in the tires. Make sure that your turn signals work, all of that stuff. That's going to be checking those things off your list. Again,
do companies provide checklists? We had like PMCs.
I can't speak for every single one, but for the most part, it's just repetition. When you come onto your truck, you know exactly, like at grading, we have different bins with different numbers, and then you're just expected to understand that equipment is in that bin, and you have to check and make sure those are all on the truck and stocked. But there's usually not like a literal checklist for all this stuff. Okay.
Is the main job of the EMT related to the vehicle?
Not the main job, but it's a big part of your job. You're still going to do patient care. You're still going to get vital signs and, do CPR, manage airways and stuff like that. But in the eyes of a paramedic, that yes, the truck is more so on you. They're going to be more concerned with making sure that cardiac monitor works, that their drug bag is stocked, that their airway kit is good. And then the rest is kind of the grunt work, maybe a little bit, but it's going to be on you guys.
The point is foundational, right?
Yes.
Everybody's got a role.
Yes.
And you got to start it.
Yes, absolutely. And guys, me as a paramedic, if I'm on a truck with an EMT, I got to make sure you know what you're doing, because at the end of the day, even if your name is on that chart, even if you provided patient care and I was driving and something bad happened to that patient, it's my responsibility. I am senior personnel. I should have known better through my assessment that they needed a higher level of care. And if I left it with an EMT who couldn't do that higher level of care, it's on me. So you guys, it's not your sole responsibility for these things, but it's just a major part of your job. Your paramedic should come behind you and make sure that they are taking your word for it, or, double check it. Yeah. Because guys, if you're partners for, years, I'm not going to question if you say everything's good to go. But if I've never worked with you before, I'm not going to say, okay, I don't trust you, but I'm probably just going to do like a walk around just to make sure you know what you're talking about. Okay. It is a team effort. So again, be familiar with your truck, be familiar with your equipment, on-scene leadership and evaluation. Okay, because guys, it's possible you could be put on what we call a BLS truck. What does that stand for? Basic life support. All right, so that means it could be you and another EMT. Technically, it could be you and you and an AMT. If you don't have a paramedic with you, you're going to be considered BLS. So it could be two of you guys in here, your first day on the job, you're both EMTs, and you get dispatched to a cardiac arrest. It's your call until somebody else gets there. All right. So even if it's a chaotic scene, you've got to be able to manage that scene appropriately. You've got to try to diffuse the situation so you can do your job. We'll talk about that a little bit later. But just because you're not a paramedic doesn't mean you're not going to have to be a leader on scenes. All right. That's with your patients, with other healthcare providers, with patients' family members, bystanders, your partner, whoever it might be. Scene evaluation, again, making sure you're constantly looking at your scene safety, looking at your patient's condition, because guys, it changes like that. Your scene safety can change like that. Your patient's condition can change like that. Okay, so don't get stagnant in understanding, oh, well, the person who shot him, they're not here now. Doesn't mean they won't come back. My patient's sitting upright talking to me right now, doesn't mean that they won't be in cardiac arrest in 5 minutes. Okay. Understand your boundaries. Understand you know exactly what you can and cannot do. If you come on scene and it's you and another EMT and your patient looks like crap, they're just sweating, they're pale as a ghost, and you'll be like, yeah, they're fine. They're not going to die anytime soon. All right. You need to know when you need to call for additional resources. When your scene's not safe, when you need to call for PD. When you need help physically moving a patient, when you need to call for fire or some more muscle. Or when your patient's bad off and you're like, I know they're probably going to die like soon, so I need to get ALS here. I need to get a paramedic here because they can do more than I can. Okay. Gain patient access, be able to develop a relationship with the patient so you can actually communicate with them. We'll talk about that a little bit later. A thorough and competent patient assessment, because we already talked about if you misdiagnose, you're going to miss what? Mistreat. Right? And if you miss something that's really, really big that you could have helped, it's going to be on you, maybe legally, and on your conscience for the rest of your life if you're not doing a thorough assessment every single time. And handling the call, handling that cardiac arrest until ALS gets there. Right? You can work a cardiac arrest within your scope. You can manage your airway and you can do compressions. That's all it comes back to is good BLS skills. I can give cool drugs. I can drop a tube down somebody's throat. I can do all these different things. But at the end of the day, good compressions and good airway management supersedes all of the stuff that I can do as a paramedic. Okay. Emotional support. Again, guys, if you're not compassionate, if you don't give two craps about the way people feel or, extenuating circumstances for, a tragic scene you're calling on, if you just have a flat affect, you're just apathetic to all of these people and what's going on, I need to rethink your career, okay? Because there are going to be some patients that are not going to make it, and ALS isn't going to get there in time, all right? Or somebody is, actively dying, and the family members know it, and you know it, and you're having to support the family members. We will talk about different things that are going to play into that, different ways to handle that, but if you're just gonna be like, dude, people die every day. It's fine. All right. No, that's not okay. Maybe reconsider your life choices in your career.
Why do EMS trucks exist if there's usually a need for like an extra?
So sometimes there's not always a need, right? Sometimes we get these, hey, my head hurts and nothing's wrong and they don't need ALS care. But sometimes it's based on the sheer volume. Like Grady, we have a big territory. We only have so many trucks on shift a day. And so sometimes we can send that BLS crew out there because we only have 5 ALS trucks. Check it out. See if they can handle that patient. And we've got this ALS crew still available for like a cardiac arrest or a significantly like a higher acuity patient. Resolve emergency incidents. That goes into managing your scene. Maintain continuity of care. Again, guys, this is making sure that even if you hate that doctor that you're giving a report to, that you're transferring that patient over to, you're still sticking up for the patient. You might swallow a pride or an ego issue just to make sure that that patient gets the treatment that they need to. Okay. Medical and legal standards, we'll get into that. Patient privacy, we'll get into that. Those are some big things that you can even inadvertently break these laws that you're upheld to, and can be bad news for you. Administrative supports, know when to call for additional resources, professional development. Guys, remember we're evolving. Be on top of the new changes, the new protocols, the new, research that's coming out so you can be on the forefront of that. Community relations, get back to the profession. If you can do community outreach, if you can help and you have any of those educational moments, then that's also part of the job that encompasses a first responder. Look at this guy. He just exudes professionalism, right? Some of the things that you really need to be in healthcare, especially in EMS, integrity, because what does that mean? What's the sign that's on all like the high school classrooms? Character is what you do
When no one is watching.
when no one's looking, when no one's watching, right? We don't have cameras in the back of the truck due to privacy reasons, but just because your patient's unconscious, unresponsive, and you think nobody's watching doesn't mean that you can steal from their purse, or doesn't mean that you can do something wildly inappropriate just because you're not going to get found out, right? You got to have a good set of moral values. Self-motivation, again, you've got to have drive to make sure that you are staying on top of being a good healthcare provider, that you do have standards for yourself. Appearance and hygiene. Why does this matter?
Because you're interacting with different people on a daily basis.
You're interacting with different people on a daily basis, okay, but why does it matter how you look?
First impressions.
Okay,
Yeah.
I literally said that at the same time. First impressions. Guys, has anybody ever had to call 911 for a family member or a loved one or somebody that you were very upset that was hurt or concerned about? One person?
Mm-hmm, yeah.
Yes.
Yeah.
So
Yes.
how would it make you feel if you haven't had to do that? Hypothetically, how would it make you feel if someone you love is either really, really hurt or you're concerned that they're going to die? All right. And the ambulance rolls up and we hop out of the truck. I got my shirt tail untucked. All right. I got a grease stain on my shirt. My boots are all shoved. My pants are all shoved in my boots. They're not tied. My hair's a mess. And I just look like I just rolled out of bed. How are you going to feel in my capability to provide for your loved one? In honesty, how would you feel?
Zero confidence.
Go well.
They can't go with you.
This
Right.
I just take care of myself at that point.
Right. Put them on my bike.
take care of themselves. They're not going to take care of my loved one. Guys, you can be the smartest, most talented, the best EMS provider in the entire country, but if you get out looking like a slob, your credit goes out the window.
Professor A, I have a question about that too, because as an EMT, I know you have a tendency to deal with all types of environments and scenarios and things like that. What do you do? I mean, do they allow you to keep additional uniform shirts or some kind in the truck, like just in case you do have a scenario where they have gotten a little messy and need to change or anything? Is that something that they allow?
So yeah, typically they encourage you guys to keep an extra uniform in your car. So if you have a call like that and you get blood on you or you get whatever on you, you can go back to headquarters and you can change out. They do have like extra reserves at headquarters, but it might not fit you or, you know, type thing. But yeah, we do encourage that you guys keep a change of clothes so you can deal with that if it happens.
Okay, because I know spaces in the trucks are limited, so that's why I was wondering.
What are like the industry's thoughts on like colored hair, tattoos, piercings? Because I have all of those.
Right. So you know how I kind of said it was almost a requirement to have like a sailor's mouth being EMS? Being weird and quirky is almost a requirement for EMS. It's almost rare to find someone in EMS who doesn't have tattoos. The hair color thing is a little bit more, they try to keep that a little more neutral. But yeah, as long as they're not offensive, as long as they don't promote like racism or nudity or anything like that, Grady doesn't care if your tattoos show. But yeah, I mean, you might have some people who have different mentalities. They don't think that somebody with tattoos or piercings or colored hair could be competent, could be smart. All right. But as long as you're put together, like you don't look disheveled, and you prove your competency, that's how we are starting to change people's minds. Because 20 years ago, tattoos were not okay in EMS, as a nurse, as doctors, but now you'll go in the Grady and you'll see, you know, a doc's got a whole sleeve. So as long as you're put together, then it's a little bit different than like physically what's on you, if that makes sense. Okay. So yeah, if somebody hopped out, if I had to call for a loved one and somebody hopped out looking like a hot mess, I'd be like, nope, send somebody else. These people, they're not taking care of my loved one. All right. What also about hygiene? What else is important? Okay, so we don't want to spread germs, right? We want to wash our hands, wear gloves, wear masks, but what else? Huh?
Smell.
Huh?
Smell.
Smell. Guys, take a shower, wear deodorant. For the love of Pete, please wear deodorant.
Please.
All right? Because it's not in any way, shape, or form like just, oh man, love the smell of BO, right? But how are you interacting with these patients?
You're like all up in there breathing.
You are all up in there, right? What if you come on scene and your patient is just nausea, vomiting, just feels totally sick, and you come on with some fresh musk because you didn't shower and you didn't wear deodorant? Your patient's going to puke because of your smell, right? What else about the back of an ambulance? Teeny tiny living space, right? Super confined. It does not ventilate very well. You're literally reaching over your patients to put these seatbelts on them, to put a blood pressure cuff on them. You're literally like right up on your patients. If you smell foul, that's not going to be good for anybody, right? And if these patients are really hurt or really don't feel good, and it's something that like you can control, you just didn't wear deodorant, they're going to be like, I need to call your supervisor. Dude just was rank. All right. So to not to exacerbate your patient's condition and to just, again, common courtesy, take a shower, wear deodorant, because it matters with those first impressions.
How often does Grady get calls that EMTs smell positively atrocious?
A correct answer on that, but I have worked with several people who I had to be like, bro, I've got some in my bag, like, take care of this. So it happens, unfortunately, more than you would think.
Dollar travel size Walmart.
Huh?
Dollar travel size Walmart.
Yeah, always. I always kept extra deodorant, a clean pair of socks, all that stuff in my bag because you just never know.
Does Grady have, or the hospitals, do you guys have lockers and stuff? Do you wash, okay, I was just curious about uniforms and everything, because again, chemical industry, we did all that at the plants, because you don't want guys take this.
You get a backpack and hopefully you remember to lock your truck.
Is there a specific brand that you recommend for like all day shifts kind of thing?
I use for her. It works pretty well. I mean, it just, you know, your body, like if you have the stress sweat, because guys, you're gonna be working in the heat of the summer too. You're gonna be out there. You might be working a cardiac arrest on the side of the road in midday heat with 100+ heat index. And spoiler alert, you're gonna be sweating your balls off. You're gonna be sweating a lot.
That's true. That's true.
So yeah, just stuff like that. I would always keep like a pack of baby wipes, extra deodorant, all of that stuff, just because you never know. Self-confidence, guys, this is a big one too. You are gonna learn, like I said before, you're gonna learn to get a good poker face. All right. Even if you come on scene, you have no clue what's going on. This is your first day. All right. Y'all are paired together. First day EMT, go on scene for a cardiac arrest. Again, if somebody calls you to take care of their loved one, you step out of that truck, you either smell or look bad. That's strike one, right? But if you get off of that truck and you've got those wide deer in the headlights, oh my gosh, I don't know what to do, or I've never done this before, or I'm scared out of my mind. How do you think that's going to go over with these people who call you, huh? Yeah, if I call somebody and they get out of the truck and they're just like, what do I do? How am I going to feel about their ability to take care of my loved one? Not good.
No confidence, yeah.
Right? So you got to fake it till you make it. You might not have a clue as to what's going on with your patient, which it happens sometimes, guys. Or you might not have ever done this procedure or intervention or whatever before. But if you let off, like if you're fumbling and you're dropping everything and you're like stuttering, everybody else is going to pick up on that. And if that scene was already chaotic because people are freaking out, it's going to go through the roof. All right, so just try to get I got this. Even if you don't got it, fake it till you make it. All right, because that will play on the environment of the people, the emotions of the people on scene, if they're picking up that you have no idea what's going on. Okay. Time management, communication, guys, this is important. We don't have the luxury to spend an hour on scene with these patients, right? We have a high call volume. Our turnover time from the time we get dispatched to the call to the time we turn the care of the patient over to the hospital and get back in service and say, hey, we're ready for another call. That should be an hour from start to finish for Grady policies because we have such a high call volume and we have such a big patient volume. All right, so being short, because guys, 5 minutes, depending on what the scene is or the call is, can either be an eternity or it can be nothing at all. So just make sure you're keeping track of, oh crap, we've been here 30 minutes, we need to go, okay? Communications is a big one. You got to be able to communicate with your patient, with their family members, with your partner, with other healthcare providers, to make sure, again, that at the end of the day, that patient gets the best treatment possible. Teamwork, respect. Another big one, guys, you can't go in there your first day as an EMT, you're green right out of the gate and mouth off on the senior fire official that's been doing it for 20 years. All right, you've got to understand that there is a level that you can kind of accrue when it comes to confidence versus cockiness. So just understand that you're not going to know everything when you graduate this course. When you graduate as a paramedic, you're still not going to know everything. When you go on to get your MD, you're still not going to know everything possible about the medical field. Guys, that's why they call it medical practice. It's not medical set in stone concrete, right? People still make mistakes. There are some cases that still be like, what? I don't know. 12 lead was good. Labs were good. This was good. I don't know what's going on. So just make sure you don't have that. You have to know everything and make sure everyone knows you know everything right out the gate. That's going to come with experience. We talked about being a patient advocate. We'll do that a little bit more in the other chapters. Make sure you're doing things appropriately and correctly. All right, we have a saying in EMS, slow is smooth and smooth is fast. All right, if you come out of that ambulance and you're trying to do things a million miles an hour and you're trying to do things super, super fast, you're gonna make mistakes. You're gonna drop stuff. You're going to not do something correctly. Guys, we gotta remember, this is not our emergency that we're responding to. It's somebody else's emergency and we're there to make it better. So you got to try to be as calm as possible. You can move a little bit slower to ensure that you're doing whatever you're doing correctly the first time. Because if, let's say you go on to AEMT and you're really, really nervous and you're trying to move really fast, and you're trying to start an IV. If you're doing it super fast and you're not thinking everything through, you're going to miss that first IV. You might miss that second IV. And the time that it takes you to get all of those second attempts, you could have done it right the first time in just a little calmer of a manner. So just keep that in mind. Compassion, respect, care. We'll talk about that in the next chapter. We'll talk about confidentiality in the next chapter. We'll talk about HIPAA in the next chapter. But again, there are certain laws and regulations you have to know inside and out to avoid lawsuits. Okay. Questions, comments, concerns on your first chapter in EMT school? Yes.
As an EMT, you have to like memorize that.
No, that is great if you do, but possibly if you work on the MIH, because the mobile integrated healthcare, they do have the ability to run some lab values on the truck. Then if that's your wheelhouse, then you would need to be familiar with those. Yeah, but not for 911 response. It's nice if you do, but okay.
What was the question? Because I couldn't really hear him.
So as an EMT, do you need to memorize like the normal ranges for lab values?
Oh, okay. Okay.
Okay. Everybody good? No questions, comments, concerns? Okay. I'm gonna remember recording.
Oh, recording.
Thanks.